Look, when a man has a low free testosterone, but a normal testosterone, they're going to be symptomatic. If the patient has a low total testosterone, but for some reason have a good free testosterone, they're not symptomatic. Exogenous testosterone is a natural contraceptive. Estrogen is so important for men for libido and sexual function. Extremely important. Some studies have shown that estrogen is even more important than testosterone in improving libido in men. You show me one other blood test that you can order today that would be more indicative of a man's overall health. It's not his hemoglobin A1C. It's not his thyroid.
Yeah.
Give me one blood test, one.
Someone flying a plane, someone operating on you,
Right.
someone taking care of your life with
Right.
your life in their hands. Should they be optimized?
I think they should be optimized, right? And the reality is, I think that everyone should be optimized.
Welcome back to the Rena Malik MD podcast, your source for evidence-based information about your sexual health and more. I'm Dr. Rena Malik, urologist and pelvic surgeon. Today, our guest is Dr. Mohit Khera, urologist, researcher, and expert in male and female sexual dysfunction. He has done groundbreaking research in the areas of testosterone replacement therapy, and he's a wealth of knowledge about sexual health. He's currently the chair of urology at Baylor College of Medicine and the president of the Sexual Medicine Society of North America. Today, we talked about the overall decline in testosterone worldwide, how your level for low testosterone might be different from someone else's based on the status of your androgen receptors, the importance of free testosterone, types of testosterone replacement therapy and alternatives, as well as the importance of a semen analysis as a window into your overall health. We also talked about regenerative therapies for erectile dysfunction, including hyperbaric oxygen, shockwave therapy, stem cells, PRP, and Botox. I hope you guys enjoy. Dr. Khera, thank you so much for joining us.
Thank you so much for having me on the show.
I'm so excited. I love your work. I love everything you do, and I'm just happy to have you here.
Thank you.
So let's start with just talking about testosterone.
Yeah.
I think that like nowadays there's a lot of fear around testosterone, like, oh, testosterone's declining and what do we do? And like, are we all doomed? And so is it true? What do you think? Are we all doomed?
Well, testosterone levels are declining. If you look at early 2000, the levels on average in young men were roughly 600, and now today they're closer down to 450. So for some reason, every year those levels are declining. Now we know there's risk factors for low testosterone. One is obesity, and if you look at a graph looking at obesity, it's an epidemic in the United States. Every decade, we are getting more and more obese, and the group that's getting the fastest rate of obesity is the adolescents. So it's not surprising that our levels of T are going down every single decade. There's other factors, there's marijuana use that can contribute as well. There's poor sleep, stress can contribute as well. So I think it's multifactorial, but I think we're becoming more and more unhealthy as a population, and that's contributing to the decline in testosterone levels.
Absolutely. And I guess the other thing about it is that people are very fixated on numbers. I'm sure you see this in your clinic. I see it in my clinic. They're like, well, my T is, 10 points lower or 100 points lower than it was before. And they might feel the exact same, but they're very fixated on the numbers. So I think you've done a lot of research on androgen receptors and how receptive they are and how the density varies. So for the average person, like, how do we figure out, outside of just basic guidelines, like, okay, 300 and above, they're normal, 300 and below, they're not normal. Like, how do we figure out that maybe somebody who's potentially on the borderline, actually they need more because their receptors aren't saturated?
Yeah, so that's a really important point. It never made sense to me that we all have this one number called 300, the men, and below 300, everyone must feel bad, and above 300, everyone must feel good. That makes absolutely no sense. I believe that every single person has their own set point, their own number. So what we did many years ago, is we still do this today, we check something called the CAG repeats in the DNA. If you look at the CAG repeats, it gives you an idea of how sensitive the testosterone receptors are. So if the CAG repeats are long, greater than 27 or greater, they have insensitive receptors. What we showed many years ago is those patients who have very insensitive receptors need more testosterone. Those patients who have very sensitive receptors need less testosterone to feel benefit. Others have shown the same thing as well. We cannot all be the same. So it makes sense. Sometimes patients walk in with a testosterone level of 250 and they say they feel great. Okay. Sometimes patients walk in with a level of 420 and they say they don't feel it. And I think we're too fixated on the number and we have to focus more on symptoms.
Absolutely. I completely and 100% agree. How are you testing the CAG repeats? Is that something that universally can be checked in the lab?
Yeah, I wish. So we do it in our basic science lab. So we have a lab, and we take blood samples for all the patients that come in for low testosterone. And it's a little bit tedious because you have to run these assays, and then you have to sit there and we physically count them, CAG. Every time we see the CAGs together, we circle it, and then we count how many CAG repeats are present, and then basically gives us an idea if they're sensitive or insensitive.
Yeah, you guys need to commercialize that.
Yeah. That's right. AI, automate it, something, yeah.
Yeah, absolutely.
Yeah.
Yeah, and I think I see it too. Like there will be people who come in, they've got low libido, they're feeling depressed, they're going to the gym, but they're not seeing results, the brain fog, and they're like, my testosterone's fine. My doctor keeps telling me my testosterone is fine. And really, they have hypogonadal symptoms.
Yeah, but think about this as one important thing we always forget. The body is more sensitive to the free testosterone and not the total. And it's been shown over and over again. But we do something interesting. We only look at the total, right? So there was one of the most brilliant scientists, Dr. Antonia out of Belgium. She showed that, look, when a man has a low free testosterone, but a normal testosterone, they're going to be symptomatic. If the patient has a low total testosterone, but for some reason have a good free testosterone, they're not symptomatic. In other words, the free testosterone is the best correlate, and we don't do that. So if you get a man who comes into your office and has a testosterone of 400 and he's symptomatic, check the free.
Right.
Because if it's low, that's a great indication to treat that patient.
Absolutely. And I tell my patients this too. I'm like, ignore the reference ranges.
Yeah.
Because for whatever reason, the reference ranges from the commercial laboratories are not based in science.
Yeah.
Right? Like
I agree. And it's random. And you can go from, if you remember the old endocrine guidelines, they stopped giving a number. And what they essentially said was use the lab's lowest reference range where you walk into. So if I walk into a lab today on street A and they give me a test and their range is 250 to 1,000 and my level is 251, I'm normal in that lab. But if I go to the next lab and their range is 270 to 1,000 and I'm 251, I'm low. I'm considered hypogonadal. That never made sense to me either. You can't use the lab's reference range because there's so much variability between every lab. Right? So it's really important to realize that this is a symptom-based condition and we should really base it on symptoms.
Absolutely. And if they're not improving with the testosterone replacement or the lifestyle changes that are improving their testosterone, then that may be that there's something else going on.
Yeah. Let me tell you an interesting story. So a patient came in the other day and they said, what is the normal range? What's the range you were trying to put me at? And I said, well, according to the AUA guidelines, we should have you between 450 and 600. That's called the mid-range. He said, okay, so you want me between 450 and 600. And I said, yes. He goes, but my lab today is 420. So what are you telling me? So I can't get T, but I'm not in the range where you want me to be. So what do you want me to do?
Right.
I don't. That's a good point, right? I mean, if really we're shooting to put everyone between 450 and 600 according to the guidelines, then maybe 450 should be the cutoff, and trying patients for a trial for 3 months to see if they benefit. Because there are patients who are going to fall in that 300 to 450 range, and they're going to say 450 to 600 is normal. Where you're trying to put me, how come I can't be there now?
Right.
Right.
Is there a number where you think that most people will reach full saturation or have full sensitivity of all their androgen receptors?
I think it's between 400 and 450.
Okay.
I do. And testosterone is very interesting. People believe that if you give me testosterone and my libido goes up, then if you give me more testosterone, my libido will go up even higher. And that's not true. We plateau. So libido, sexual function, everything plateaus at a certain number. So doubling it, tripling it doesn't give you more benefit. The one exception is muscle. So if the body sees more T, it will make more muscle, and that's fine. But in all the other symptoms, giving you more once you've reached the plateau is not going to help you.
So what about if you take testosterone and your levels are 1,000, 1,200, 1,300. So they're super physiologic based on the numbers that are given in the lab and the numbers you're quoting.
Yeah.
What is the harm in that? I think a lot of people are like, well, I want to be at that number.
Yeah.
Why can't I be at that number?
Yeah, so there are some risks. The one risk is the risk of erythrocytosis. So clearly the higher the level, the greater the risk that your blood count will get thicker. There is a theoretical risk that when it gets above 54, your hematocrit, you could have an increased risk for cardiovascular events. It's a theoretical, and we can talk about that. So that's the main concern. If you said to me, show me the study that shows that 1,500 is dangerous, it's going to be very hard to produce it. Theoretically, it makes sense. Like, hey, the range is 300 to 1,000. Why would I put someone at 1,500? But there's not a lot of great data on supraphysiologic levels. There's some data on cardiomyopathy and thickening of the heart. There could be some issues with that. Very poor data, but it exists. But the main concern is erythrocytosis. Some patients will get roid rage. I've seen it. So you get very high, they can't get roid rage. And I do see an increased risk in hypertension. So patients can get an increase in the blood pressure. So there are some risks. But my question to that patient is, why do you want to be at that level? Right. What are you trying to achieve? You're not going to double libido, double erections. So there's got to be a purpose. And I think they just feel that if I'm good at 700, I'm going to be better at 1,400.
Right.
And it just doesn't make sense.
Yeah. No, I completely agree. I think it's important to sort of explain that to people. But yeah, people feel like, and I think it's also a male thought process, right? I want to do the best I can, be the best I can. If I tell my male patients to do something, they're going to do it 10x, right? And I always tell them, don't do it 10x. Do what I'm telling you to do. Yeah. And I think they feel the same way when it comes to testosterone, because it's so linked in their mind with like masculinity or having these, like all these positive attributes.
Yes. I mean, look, there's other ways to achieve that. You don't have to just get it with testosterone.
Right.
Diet, exercise, sleep, stress. We've talked about this many times. Testosterone is a component. It's a tool to reach those goals. Many people say, give me the testosterone, everything's going to be great. No, it's going to help you, but you got to contribute. And so that's where you want to really kick in all those other lifestyle factors with T.
Yeah, I agree. Let's then talk about the different types of testosterone replacement. So let's sort of summarize what are the different types, and if you were to which ones are more effective or less effective, and which ones are more risky and less risky.
Yeah, so I tell patients, it doesn't matter if I give you a gel, an injection, a patch, it's all the same drug. I'm just giving it to you with a different formulation, a different way to get it into your body. So one's not more magical than the other. It's the same testosterone, right?
Yeah.
So I say, how do you want to get it into your body? So we came up with something many years ago called the 4 C's: cost, compliance, convenience, concentration. So everyone has a different aspect. Some are too expensive. Some don't get a good level. Some say it's not convenient. Some forget to be compliant. So we look at the 4 C's to let them know. But the reality is that the most commonly used testosterone today is injectables. And it's the injectables that you get at a compounding pharmacy because they're very cheap.
Yeah.
So they spend $30, $40 a month, no insurance. It's shipped to their house. They inject. Most of my patients will inject sub-Q, and we'll talk about that. And we like to have them do it twice a week. Because if you inject sub-Q twice a week, you mitigate the erythrocytosis rate, because erythrocytosis is because of the large spike. We have them inject on Sunday and Thursday. Why? Because it peaks in 24 hours, and everyone wants to be ready on Monday and Friday.
Yeah.
Right? So those are your big days. So we're typically using 0.25 cc's twice a week or 50 milligrams twice a week to get them started. So injectables, to me, I think are very good. I think the orals are fantastic if you're willing to do it twice a day.
Yeah.
They're very effective. Americans, most people are okay taking a pill. That's what they do. They have pill boxes. They remember. Remember, in the United States, we did not get orals till 2019.
Yep.
And then we got 2 more later in 2022. So today we have 3 oral testosterone products, but the rest of the world got orals since 1970. So they've been having andriol for many, many years. Benefits about the orals is that they have the least rate of erythrocytosis, which is less than 5%, very low rate of hypertension, and they give good levels. So to me, it's probably the safest form of testosterone.
Yeah.
You just have to be compliant. But there's 3 types. Kaisertrex is the one that's now not through insurance. It's excellent product. You take it twice a day. All of them twice with food. Yes, with food. So that's very important.
So if you're fasting, not a great idea.
Intermittent fasting is not going to work. Tolando, 1 pill, 225 milligrams twice a day. I mean, 1 dose, 225. And the Jatenzo needs to be titrated. So they all have like nuances. We're doing a study with Kaisertrex. I think that the orals don't suppress spermatogenesis. That's important.
I agree with you.
Yeah, I think so, because I don't see a significant decline in LH and FSH when I gave patients orals. So we started a study where we give these men oral testosterone, Kaisertrex, and we get 6 semen analyses. And we presented this at the SMSNA last year. 80% of patients don't see a significant decline in spermatogenesis. 80. But 20% do see a significant decline. So I don't want the message to be that it's 100% safe and don't worry. Some people do decline. But the fact that you can use an exogenous testosterone and not see a significant decline in spermatogenesis in most patients is fantastic. So more to come on that study. We haven't finished it, but that's going to be, I think, a really big deal if we can show that it doesn't suppress spermatogenesis.
Yeah, I mean, I think it makes sense, right? The half-life is, I think, 2 hours, right, for an oral. And so about 6 hours, it's like gone from the system, 6 to 8 hours.
Yes.
And so you're not covering 24 hours.
You're not. But remember, Natesto was the same way. It was a quick up and down. So, and they didn't see a significant decline in the nasal testosterone either.
Yeah.
I think that's one of the characteristics of this medication, that it actually doesn't cause a significant suppression because of its pharmacokinetics. I do something a little bit different. I don't like giving it at lunch and dinner. I like to give it lunch and breakfast because I like to get superimposed the second curve on the first curve and get most of the effect during the day.
And that's more biologic.
It's more biologic, right?
Yeah.
Circadian rhythm. So it makes more sense. And so most of my patients, now again, it's off-label use in that way, but I still think it works better. Patients do better when you give breakfast and lunch. So that's the orals. I think the ones that I still use a lot of pellets. I do like the pellets. Just remember that the pellets, you're dependent on me. You have to come in and see me every 4 months. And towards the end, a lot of patients are subtherapeutic.
Yeah.
So they have to kind of, last month maybe a little tough for them. Sometimes I have to supplement with a gel.
Yeah.
My least favorite probably are the gels, to be honest with you, because they're dependent on skin penetration. So I tell the patients, this is the formula. It's milligrams times percent penetrance. If I give you 1,000,000 milligrams of testosterone and you have 0% penetrance, you get nothing.
Right.
You get nothing. And so a lot of these, we showed this many years ago in one of our studies that 20% of patients didn't absorb androgel, like the gel.
Yeah.
Okay, so 20%, but a good portion did. But, again, and even if you're an absorber, you may be a partial absorber.
Right.
You just really want to, the gels, I think, are, so that's I still like them, but I just think that there's a rule for those.
It's also quite a bit of gel.
Yeah.
Like if you think about it, like 5 cc's or whatever, I think it's 5 cc's, right? It's a lot. It feels like a lot to put on your arm and then rub it in and make sure it actually absorbs and doesn't like fall everywhere.
Yeah, be careful about transference. Be careful there's a pregnant woman at home or a young child. But, there are a lot of patients who say, I don't mind. I like the gel. And I say, great. As long as you get a good level, let's keep going. But besides the injectables, and I like the Zyosted because that's so easy.
So easy. Yeah, but really hard to get coverage.
But if you can get coverage, it's
and
fantastic.
And Zyosted, just to clarify, is it like an EpiPen type version of testosterone?
Yes, and it's so easy. And you get 4 pens a month. You just inject and you throw it away. And so it works very well. So if you get covered, it works. But I think injectables, the orals, and then pellets and gels are kind of where I kind of sit with all the testosterone products.
Yeah, and there's no patches anymore, right?
No, and I work at the VA, so we don't have patches there anymore either.
We barely. I work at the VA too. We have like 2 options.
Yeah, but the patches, and the patches, 37% had skin reaction, blisters, and they didn't absorb very well, so didn't make a lot of sense. But we should talk about meds for people who want to preserve fertility.
Yes.
Yeah. So everything we're talking about is patients who say, I'm done with having kids, don't want to have children, we're good. But I just want people to know that, and this, exogenous testosterone is a natural contraceptive. You do not give people testosterone who are trying to conceive. The AUA had a survey that they sent out to urologists many years ago, I don't know if you remember this, where 25% of urologists said they would give testosterone to men who are actively trying to conceive, which is scary, right? Because we're the experts.
I don't remember that.
Yeah, so
really scary.
So I said, okay, wait a minute. So it's very important to realize if you are trying to conceive, plan to conceive in the future, be very careful because exogenous testosterone can shut you down. So what do? We use medications to make you make the testosterone. Right. That's safe, and it increases your natural testosterone production.
Yeah.
So the most commonly used ones are SERMs, like clomiphene citrate or Enclomid, and then the other ones are HCG. I mean, those are the most common. Sometimes, rarely, I'll use aromatase inhibitors like Arimidex. If the LH and FSH are already high, like in a Klinefelter's patient.
Sure.
Because giving a Klinefelter's patient more Clomid and HCG is not going to make a difference. But Clomid seems to be the go-to because it's cheap, it's a pill, easy to use.
Yeah, so I do want to clarify that, yes, it will likely make you infertile, but it's not 100%. I think it's like 80%, right?
Well, it varies. It varies on dose.
Yeah, because people will always comment like, oh, I got pregnant, or I was on steroids, I got, I've conceived, my wife conceived.
Yeah.
And just to be clear, it's not 100%, but it is more likely than not.
Yeah, and agree. It depends on dose and how long you've been using it. So you're absolutely correct. Please, no one think that I'm taking testosterone and it's a form of birth control. It is not a form of birth control. Like at 200 milligrams a week, patients can become azoospermic within 90 days. So 200 milligrams a week, that's a high dose.
Yeah.
But what we started looking at was something called 17-hydroxyprogesterone on all patients. That is a marker of intratesticular testosterone. Intratesticular. So every patient gets that. And studies show that the intratesticular testosterone levels go down within 3 weeks. So 94% reduction in 17-hydroxyprogesterone within 3 weeks. So the testicles will start taking a hit sooner. The blood levels will start seeing declines. Your ejaculate will see a decline later. So we use that as a marker. So I agree. If you want to use testosterone, also remember, many of the clinics say if you stop, you will recover. And that is true. You can recover, but it doesn't mean you'll recover back to baseline, right? So if a man starts at 80 million sperm per ml, and I make him azospermic, which means no sperm, after giving him testosterone, and he recovers to 20 million per ml, well, he did recover, but he's only a fourth as fertile as he was before.
Yeah.
Right? So it's a little misleading. Yes, you can recover, but you may not recover back to baseline, which will induce some degree of infertility.
And how long it takes to recover can vary person to person.
It can vary person to person.
Depending on how long you were on it.
And there's a race, how long you've been on it. That dose is important if you're taking 200 milligrams a week. And so all of that matters. Now, there's things we can do to help you speed it along. So a lot of patients will come, they're azospermic, they have no sperm. They say, look, I've been taking testosterone. I didn't know this would make me infertile. Can you help me? So we have protocols. We can give them HCG. We give them FSH. We inject them. And usually we tell them, our studies show that they recover on average about 7 months. So I say, look, it'll take 7 months. Or sometimes patients say, I'm on testosterone. How much leeway should I give you when I want to have kids? I say, give me 7 months ahead of time notice so that I can start getting you on the protocol to help you recover. It's not going to happen overnight.
Right.
You know?
Right. And there is a protocol, and you can sort of wean off the exogenous testosterone, add those medications, and that can get you back.
Yes,
quicker.
there is. There's some data now even suggesting that if you give HCG and FSH while they're on T, you can see a recovery of somatogenesis while they're still on T. I still prefer if they'd come off, but some don't want to. So I always tell them, don't stop cold turkey. Wean 50% every 2 weeks on the T. Just go slowly, because if they don't, they sometimes feel bad and they go back.
You mentioned you work at the VA. There's an interesting thing where if they start on T elsewhere at the VA, they have to go off their T and recheck their labs, which I'm like, that is so mean.
Yeah,
patients,
it's true.
Right?
No,
like
it's
they're
true.
going to feel miserable.
Yeah, but they want to document. Sometimes, though, there are patients who are started on T who were never supposed to be on T.
Yeah.
Like they were started at 450, 500, and so how do you know? Do you take over that patient and assume the risk that someone else was doing it right? I mean, I always say, hey, you must have had some levels before you started. Can I just look at those levels?
Sure.
And most people can get me the levels. So
but I wonder if they're doing well and their numbers are within the normal range. Like, is there harm then in that case?
Yeah.
Like, say maybe they didn't really need it. Maybe they weren't symptomatic and their numbers were just a little low or you know, but they are feeling well and they're on it and their numbers are within the physiologic range. Is there harm in that?
Yeah, I think the only harm is like what you would treat anyone else for. If they said, I felt better, I had symptomatic improvement, there's no erythrocytosis, you're not seeing any side effects, one could argue, well, they're benefiting, and could you let them continue? I think from the only part would be, one, insurance coverage. So insurance is going to say, we're not paying until we see the numbers, typically. And I think that would probably be the biggest impediment.
Yeah, I agree. I mean, I think, I'm with you. I think that if they're doing well, they're feeling well, they're symptomatically seeing an improvement and their numbers are safe and everything looks okay, I think that it's probably reasonable to keep them on it. Yeah,
I still like to see the low number. I just do. I do. And sometimes I will actually ask them to stop. I know it doesn't sound very nice, but I'll say, can you stop and let me see the low number? And they, if they've been on exogenous testosterone, it will suppress their endogenous and it will come back low. But I say, if you can't show me that it was low, I really would feel better knowing that you truly are low before I start you.
I had a question about Kaiser or oral testosterone. When I'm checking these patients' levels, and I think, again, people get very fixated on the numbers, but if they took their morning and lunch, when they wake up the morning, if they don't take their testosterone before their blood work, it's going to be relatively low.
Relatively low, that's right.
Right? And so I tell my patients that I warn them of that, but I think if anyone's taking orals, it's important to realize that if you take your blood work before you take your oral, it's going to look low. And if you take it right after you take your oral, it's going to look really high.
Exactly. That applies to anything, even injectables.
Right.
If someone takes an injection once a week and they come to see me the next day after the injection, it's going to look higher.
Right.
If they come right before the next injection, it's going to be lower. You can game the system quite a bit on when you check on anything based on what kind of modality it is and when you gave yourself the injection or the oral. So I think it's very important to know when you are checking patients' blood levals to say, when did you take your last testosterone pill or injection or gel, you should document in the chart just so that when the blood levels come back, you have a rough idea of where they were. I think that's very important. But, people get so fixated on the number. Like, if a patient says, I'm 800 and it goes down to 700, and he'll call me and say, what's going on? Like, I don't understand. I say, look, there's a lot of volatility, even the time of day when I check this, even on exogenous. Remember, even if there's not a lot of testosterone in the blood, the receptor is activated with the testosterone, and the activity of that receptor can go way beyond what's in the blood.
Right.
That's why Natesto, I thought, worked, because when I looked at the PK values on Natesto, it was quickly in the body, that nasal testosterone quickly went out. And I said, this never makes sense. If I look at the graphs, it's really not in the body that long, but patients were feeling better, right? Because the activation of the receptor goes long beyond what you see in the blood.
Right.
Yeah.
Are you sick of going to the doctor only to have them talk at you for 15 minutes and leave without knowing exactly why they're prescribing you this certain medication and what exactly the next step is to take to optimize your health? Wouldn't it be great to finally find a doctor who actually listens to you, answers your questions, and doesn't rush you out the door? Well, at my practice, Rena Malik, MD, I aim to do just that. I specialize in taking care of patients who have issues with their sex lives, issues with their bladder, with their hormone health, or are having pain in their pelvic region or with sex. My goal is to give you the time and attention you deserve so you can leave with a clear understanding of your condition as well as our treatment plan that's optimized for your goals. During your visit, I'm 100% present with you for an entire hour. And after you leave, you can reach me. It is super easy to send me a message through our secure portal, and I'll get back to you within 24 to 48 hours. No questions asked, no hidden fees. Scheduling is easy. Just visit our website, renamalikmd.com/appointments. We see patients in both Irvine and Beverly Hills, California, and I see patients virtually in California, Florida, Illinois, Maryland, New York, New Jersey, and Virginia. Oh, and don't forget Texas. If you're outside these states, consider seeing me for an educational visit. I look forward to seeing you. Yeah. And the other question I get often to talk about some of these off-label options for fertility preservation, the difference between Clomid and enclomiphene.
Right. So Clomid has two isomers. It has the cis isomer and the trans isomer. And Clomid is FDA approved for women. It's a fertility drug. So for women, they can take Clomid and it induces ovulation. So we started using it in men. Probably 30 years ago, you've been seeing men using Clomid because it also increases LH and FSH in the brain, and it actually induces somatogenesis and testosterone production. But it has two isomers, a cis isomer and a trans isomer. And it's Zoclomid and N-Clomid. N-Clomid is the trans isomer. What's nice about N-Clomid by itself is it has a much shorter half-life and has a less estrogenic effect. So for many years ago, probably about 10 years ago, a company called Repros Pharmaceuticals tried to get N-Clomid through the FDA. And it was called Androxyl was the name of the drug. And it never made it through the FDA. And I think really because around that time, there was a lot of concern that testosterone may cause a heart attack. And there was a lot of concern at that time, and it was really difficult to get it through. So they tried to get it through, and I think they're still trying to get it through in Europe. But in either case, so it's not, N-Clomid is not FDA approved. Clomid is, and Clomid is used off-label in men, but N-Clomid, you can still get it through a compounding pharmacy. We did a study looking at men who were using Clomid, and then there was a shortage of Clomid. We couldn't get it anywhere. So we switched patients from Clomid to N-Clomid, and then we studied them. And we found that the patients who were switched to N-Clomid had better symptomatic improvement and less conversion to estrogen and slightly higher levels of testosterone. So we published that paper just showing, so N-Clomid may have some beneficial effects over Clomid, but again, it is not FDA approved and not on label for this indication.
Yeah, well, neither is Clomid.
Yeah, neither is Clomid, at least, but it's FDA approved.
Sure,
sure. That's right.
So, and then in terms of, there was, I think, a paper you wrote that showed that some of these medications, HCG and Clomid, they do really good with the lab numbers, right?
Yeah.
Your testosterone goes up, but not everyone sees symptomatic improvement.
I think that's such an important point.
Yeah,
because we should backtrack. Estrogen is so important for men, for libido and sexual function. Extremely important. Some studies have shown that estrogen is even more important than testosterone in improving libido in men. Right?
Yeah,
There's
that's
been shown.
so important.
Really
That's
important.
so important.
And when I was doing my training, we were taught that, estrogen for women, testosterone for men don't need estrogen, and we would give them anastrozole and shut down their estrogen pretty low because they didn't need it. Well, we were wrong, right? We were wrong because we found that these men felt lousy and their libidos went down. So estrogen is a key driver for libido and sexual function. Well, the way Clomid works, it blocks the estrogen receptor centrally in the brain. So it blocks the receptor and it kicks up the testosterone. And so in all the estrogen that's floating around, it can't see the receptor because it's blocked by Clomid.
Yeah.
So if the testosterone level goes up to 800 on Clomid, I think roughly 40% of patients will say, I know my number is good, but I don't feel it.
Yeah.
I take that same patient and I put him on exogenous testosterone, like testosterone injections, put him at 800. He says, I feel it, right?
Yeah.
Because I feel like I'm not blocking the estrogen receptor. So men need estrogen. The benefit of HCG is HCG is just an LH analog. So it doesn't need the pituitary. It doesn't block any receptors.
Yeah.
All it does is go straight to the testicles and start producing testosterone.
Right.
So patients on HCG also tend to feel pretty good. And I think HCG as monotherapy helps with libido. So if I have a man on testosterone and his levels are 600 or 700, he still has low libido, sometimes I'll add HCG because I think it does help with libido in men. So I think there's nuances, but remember, Clomid can be a little bit problematic when it comes to symptomatic improvement.
Do you ever do HCG and Clomid? Are there indications where you use both together?
I do. So this is the only time. So let's say a patient comes to me and says, I want to improve my fertility. My testosterone, give me the strongest thing on the planet that will help me become more fertile. And my testosterone is low. I say the strongest thing on the planet that I can give you is HCG plus FSH. If I give you HCG and FSH, there's nothing more I can give you to help you recover your sperm production. It's extremely expensive.
Yeah.
Like it's especially the FSH, right?
Yes.
So they say, look, I can't pay the $600 or $700 a month. It's very expensive. What else do you have for me? I say, okay, I'm going to give you the HCG in combination with Clomid. Because if I give you Clomid with HCG, the Clomid can actually help with some of the FSH component, and the HCG will help, and that's my second favorite. If he says, look, I don't want to inject, and maybe HCG is too expensive for me, they say then we go down to just Clomid. Right? So the lower you go, the more inexpensive, but the less effective, right? And so that's kind of how I gauge which one to do.
In terms of testosterone replacement, right? Or even these off-label options, I think that a lot of men are very fixated that testosterone is going to fix all their erections. They have erectile dysfunction or they're not as strong as they used to be, and testosterone is going to fix it. And you and I could both agree, and I say this all the time, that really isolated hormonal problems are like 6% of the population that have ED. But what percentage of men do you see that notice like that they're completely, in your practice, they're completely cured with testosterone?
It all depends on certain baseline demographics. So I just want to give you an example. So there was a large trial called the T trial. The T trial came out in New England Journal of Medicine. This was 2016, showing that men who had low testosterone levels, when you put them on testosterone, had an improvement in erections and they had improvements in sexual function. And then came the Traverse trial. And the Traverse trial came out showing, this is 5,200 patients, but the subset study was 1,100 men, sexual function, randomized placebo, and they looked at increase in sexual performance or activity and IIEF, meaning erections. In that trial, men had an improvement in sexual activity, but they did not have an improvement in erectile function. So which patients tend to benefit the most? I think it's patients who do not have a significant amount of comorbid conditions, right? Because if you have significant diabetes, obesity, it's hard for me to imagine that I just give you testosterone and the whole world is cured.
Right.
It helps. The second component of the patients is whoever starts very low. The lower you're starting, the greater the improvement, right? And we've seen that, and Dr. Corona has shown that as well, where the greater the delta, the greater the improvement. So patients with not so many comorbidities, I think mild ED, and the lower the T levels, tend to do better as monotherapy. Now let's hold this thought, because we're talking about giving T as just a simple drug to help with ED. In 2018, when we wrote the guidelines for ED, testosterone is not a treatment option for erectile dysfunction.
But it's recommended to check it.
To check it. So that's a great point. So you would say, why are you checking it if it's not a recommended treatment? And the reason we put that in there was because data would support that PD5 inhibitors like Viagra, Levitra, Cialis are more effective when you give a man testosterone in combination if they're hypogonadal. So the best example is a man comes in, his levels of testosterone are 200. He says, my Viagra is no longer working. You say, okay, Mr. Smith, let me put you on testosterone, and then you raise his level to 600, and 30 to 50% of those men will say, my Viagra's now working, right? So it basically takes PD5 non-responders and makes them responders, right? And so combination therapy makes sense. But I do think monotherapy in a select population of patients, not so many comorbid conditions, very low T levels, probably younger, mild ED, they actually do better than most in raising those natural, improving their erections.
Yeah. Well, the T trials were an older population,
Yes.
right? 65
65
and
and
above?
older.
Right.
Right.
Yeah. And the Traverse trials was 55 and above?
Yeah, so 45.
45.
Yeah,
Okay.
so you have a group of patients who were above 65 and below 65. And what was not fair about the Traverse trial was that 12% of the patients in the trial for the sexual function didn't have a sexual partner. So how are you going to know on your II? You don't even have a sexual partner.
Yeah,
Then,
your II is zero.
Zero. And on the Traverse trial, remember, in order to get into our trial, you had to be really sick. You had to have increased cardiovascular disease or at least three of the 8 cardiovascular risk factors, right? 50% of those patients had cardiovascular disease and they had diabetes, hypertension. They were a sick population of patients. And so now you have a sick population of patients who may not be even interested in having sex because they don't have a partner. And so you're going to tell me that they're going to have a significant improvement in their erectile function. One of the other problems with the Traverse trial that brought up was that our definition of normal was above 350. 350 to 750, right?
Yeah.
Now, that was a trough number, but it still was at 350, so it's kind of hard to say where they exactly were. But some were criticizing and saying, look, if your number comes in at 370, you're telling me that's normal? You know, if you look at other trials like the T4DM, which was given with Nabita, which is a long-acting injectable, those levels were in the thousands, and we see different kind of results with those. But some would say, I don't know if your levels were high enough in the Traverse trial to really make a difference. So that may be just another confounder.
The other thing in the Traverse trial was you studied gel, right? Androgel.
Right.
And then that, I think I heard people sort of criticizing, well, you don't know if that's the same for injectables or you don't know if that's the same for other formulations.
Kind of. Yeah, I agree. So there were 7 trials in the Traverse trial. And if you look at safety, 2 of them were safety. One was cardiovascular, one was prostate. In terms of prostate, I believe in something called the prostate saturation model. And we've shown that it's roughly around 250. So if a man is below 250 and you raise his testosterone level, PSA will go up. You'll start seeing a slight increase in prostate volume. We do. But then it plateaus.
Yeah.
Right? So if you take someone who's under 250 and I put them on gel and put them above 350 or 400, it's not going to change much if I take them to 800 in terms of prostate safety,
right.
I think. Cardiovascular is a little bit different. Because the higher the T level, as we mentioned earlier, the higher rate of erythrocytosis, the higher rate of potentially hypertension. And so I'm not sure if it's completely translatable from a gel to an injectable. You know, and not completely for cardiovascular risk. And so I think that's something to keep in mind. The other findings that we found, there were 2 statistically findings. Atrial fib, 1% was increased. Chronic renal insufficiency, 1%. 1% were not adjudicated, but I have to admit that they were there, so we acknowledge that.
Sure.
And then pulmonary embolism comes up quite a bit, but it wasn't an endpoint, and it wasn't statistically significant. Essentially was 0.5% versus 0.9% difference in those men being treated with testosterone versus placebo. So people kind of bring it up, but I say it wasn't an endpoint and it wasn't actually statistically significant.
So do you think, I mean, obviously based on the Traverse trial, I think we feel a lot more comfortable with testosterone, but do you think that, for example, injectables, based on the totality of the data, that there's a concern for cardiovascular disease with testosterone replacement? I
think that before even the Traverse trial, there were only 4 studies coming out suggesting that there was an increased risk. And those studies were poorly designed, 3 retrospective, 1 no control group, suggesting that there was some mild increased risk. The majority of studies have shown no significant increased risk. And there's 200 plus studies suggesting no significant increased risk. I firmly believe that a man with low testosterone is at an increased risk of cardiovascular events, an increased risk. And so I think there is more detriment to leaving that patient low than raising his levels to the normal range, even with an injectable.
And then in terms of, we didn't touch on this, but like there's obviously conservative lifestyle changes you can do to improve your testosterone. So one, what are those? And then what sort of increase can you see with just conservative treatments? Yeah,
so the problem with lifestyle modification is that each one individually offers just a small amount. Okay, so there's one study looking at diet and exercise. One study showed there was a 25 nanogram per deciliter significant increase, but it was statistically significant, but you and I know that 25 is not going to cut it. And some studies will show up to 100. Okay, fair. good, but not going to change the needle too much. But how about obesity? Now, obesity is probably my most important lifestyle modification, because there's such a strong bidirectional relationship between obesity and testosterone levels. If a man loses 10% of his body weight, his testosterone goes up by about 85 nanogram per deciliter. But if he loses 15% of his body weight, it goes up to 250 nanogram per deciliter.
That's a lot.
And it's a lot. And the best data is in the bariatric literature, where they do bariatric surgery, they lose 15% of the body weight, and they really gain a lot of T. Now, with the GLP-1s, that's actually changed the paradigm too.
Yeah.
Because when these patients are losing a significant amount of weight, now they can actually keep the weight off and their T levels go up. Because before, when they used to lose 10 to 15% of their body weight, most of the time, they gained it back.
Right.
So then what are we doing? So that's important. So GLP-1s has helped quite a bit. And so I think weight loss is important. Sleep apnea. So some studies have shown, that if you improve the sleep apnea, you can increase it by 100 nanogram per deciliter. Varicocele repair, anywhere from 85 to 95 nanogram per deciliter can improve as well. So if you add it up, I sleep apnea, lose the weight, I do some exercise, you add it up, then you'll notice that there may be some benefit. Stress also and sleep.
Yeah.
So if you mitigate your sleep, if you reduce your sleep, you can see significant 10 to 15% decline in serum testosterone levels. But the second half of the night is more important than the first. So let's say you went to bed from midnight to 8 a.m. and I didn't bother you from 4 a.m. to 8 a.m., you don't see much of a decline, right? But let's say you slept great from 4 a.m. to midnight to 4 a.m. and I started getting some phone calls at 5 and 6 a.m., you start seeing the decline. So that second half of the night is more important. So all of these things are additive, right? All of these are additive, and I think that if you do these and you can change your lifestyle modification, you can actually see a sustained, significant increase in serum testosterone.
And the stress literature is tough. I mean, there's literature on like residents, like I think it was one study on male residents and other like high stress occupations, but it's very difficult to study stress.
It's very difficult, but I was just invited to give a lecture at SOCOM. This is the military, like the Navy SEALs and the Rangers, and it's a condition that's been out for a while called operator syndrome. And what the military is noticing is that when you go through military training and then you go through something like Hell Week, the testosterone levels significantly decline, right? Cortisol levels go up, and these patients, soldiers, even after the training is over, see a sustained decline in serum testosterone levels several weeks after stopping. So it's called operator syndrome. The stress on the body can significantly reduce the testosterone in men and women, right? In men and women. So the question is, what should we do? So if you look at two soldiers in the military, and one has a level of 320, which is normal, and the other one has a level of 800, right? Clearly the one with 800 has a significant advantage than the one with 320. And unfortunately, at 320, you can't treat because it doesn't meet the guidelines. The military uses the AUA guidelines of 300, right? So just from a combat military point of view, should we consider doing things to raise the testosterone level in men who are low normal, just to give them a safe way? In a safe way to give them an advantage. Because I think cognition, muscle mass, bone mineral density. I mean, I can go on and on about the beneficial effects of testosterone. And if you have someone in the battlefield, I want them to have every advantage they can have in order to be successful.
But you could extrapolate that. So you and I know this from urology, like you have to treat kidney stones in pilots, for example, because you don't want someone flying a plane and having an issue with a kidney stone. But like someone flying a plane, someone operating on you, someone taking care of your life, with your life in their hands, should they be optimized? I
think they should be optimized, right? And the reality is, I think that everyone should be optimized.
I agree.
Like, everyone should be optimized. There's something to say about improving your quality of life. Now, every time we talk about testosterone, we talk about libido and energy and sex drive, but let's talk about the real deal here. There are 5 things that can happen if your testosterone is low, and these are pretty significant. You're at a significant increase in having a heart attack, which we talked about. Significant increase in osteopenia and osteoporosis, right? Significant increase in depression was one of our papers. Low T significantly reduces depression in patients, right? It is associated with prostate cancer. I'm not saying it causes it, but we know that men with lower T levels are more likely to have prostate cancer. That's very important. And we also know it's associated with diabetes and obesity. If you give someone Lupron shot, in 3 months, you will see them hemoglobin A1C rise significantly. We see this. So diabetes, obesity, metabolic syndrome, depression, prostate cancer, cardiovascular risk, bone fracture. You show me one other blood test that you can order today that would be more indicative of a man's overall health. It's not his hemoglobin A1C. It's not his thyroid.
Yeah.
Give me one blood test, one.
That does all those things.
That shows me more indicative of a window of his overall health. That testosterone is the best barometer of a man's overall health, right? It's the best barometer. The second question should be asked, well, if I give you testosterone, will I improve those 5 things you mentioned? Right? I mean, that's another topic. And that's where it starts getting a little bit controversial, because we do know that if I give you T, you will increase your bone mineral density. You can, but does that decrease bone fractures? Not have been shown yet, but I think we need more data, right? If I give you T, will that help with cardiovascular disease? Some people believe yes. I believe yes, but we need more data, right? We do know that giving T does help with obesity, and we do know that giving T actually helps with diabetes. That was a T4DM trial.
Yeah.
Right? 13% reduction in diabetes in those men taking T. So that's been shown well. And you look at prostate cancer now, there's this concept called BAT, bipolar androgen therapy. How do we treat men with metastatic prostate cancer? If you walked into Johns Hopkins today, they give you high doses of testosterone to treat your metastatic prostate cancer. Bipolar androgen therapy would have been unheard of like 30 years ago.
Yeah.
But that's how we're treating them. And in the first study that came out in 2015 was a 50% reduction in PSA, 50% reduction in metastatic disease. Later on, they did the Transformer trial, also showing that there's increase in overall survival, or no difference in survival with testosterone with enzalutamide.
In terms of, the one thing I think that's still the unquestionable, right? These people between, let's say, 300 and 450.
Yeah.
And if you treat those people, are you still going to see those same benefits?
So the thing is, you don't see as much, right?
Yeah.
So there have been studies looking at men who are above 300 and below 300. And those men who are in the eugonadal range don't tend to see the benefits than those in the hypogonadal range. Now, some do, because I still believe we all don't have one number.
Right.
So in that 300 at the 450, there may be people who are below their set point, right? But the higher you get, the more likely you are to cover everybody.
Yeah.
Right?
Right.
So it makes sense that if it's at 200, most people are not saturated, and so they're going to see a benefit. As you get to 400, most people are going to be, and so they're going to see. So as we get higher, it's less likely to see benefit.
And then what's the range that you use for free testosterone in terms of when do you feel like that's saturated versus not?
Yeah, so free testosterone typically is 50 to 250 picogram per milliliter. That's the range.
Yes.
I typically like to keep the patients around 200, just in the upper normal. I always like to pick the upper quartile of normal, right? You look at your range, upper quartile of normal typically is where I think most people do well. There's no harm in putting someone in the upper quartile of normal. And if you do, you're probably saturating most people, so you're not having to titrate more over and over again. Yeah. So that's typically the range that I use.
Yeah. And I think it's interesting because some of the reference ranges will come back at like 60 is normal, 50 is normal. And actually, isn't it like 5th percentile is 75?
Yes, that's right. Yeah. That's exactly right. So, but we're still fixated on the why. I mean, if I start someone at 70, if he's a 70 free, could he benefit? Yeah, he still could benefit. Right? He still could benefit. Yeah. So I don't get so fixated on the numbers. Even when I treat women, it's a symptomatic disease. Absolutely. I'll give you an example. Like, if you look at women in the United States and we treat women who are postmenopausal, they come into your office, she's 55 years old, and she says, "Doctor, I have hot flashes and they're very severe and I'm just not feeling well." The standard of care in the United States is to give her estrogen. And if she has a uterus, you give her progesterone with it. Fair enough. We don't check the level. The standard of care is not to check the level. The standard of care is to give her the medication, and she's on her way. Then she comes back a month later and she says, "I'm feeling better, but I'm only 50% better. I still have the problem." What do we do next? We up the dose on the estrogen without checking the level until she feels better. Yes. Right? That's the standard of care. But with testosterone, it is like a crime if you don't check the level and make sure that, so there's a little bit of differences here, but I think this is a symptomatic disease and we should be more driven on symptoms.
I agree with you. I agree with you 100%.
Yeah.
Quick break from this episode to let you know I am so grateful that you're spending part of your day with me. I started creating content online to empower people to learn more about their bodies without needing to go see a doctor, pay a copay, wait in a waiting room, or find parking. And it has been one of the most rewarding experiences of my life. If you want to help support our mission of providing free education, please consider joining our premium membership. There you will have access to ad-free episodes, which are released early, as well as free transcripts and the opportunity to ask me anything. And these questions are answered in our monthly AMA episodes. Support the show and join today at renamalik.supercast.com. Can't wait to see you there. In terms of, you mentioned earlier varicocele repair.
Yes.
So varicoceles can range from being symptomatic to not symptomatic, and sometimes they're not symptomatic. In those patients, and a varicocele is essentially enlargement of the vessels in the scrotum that surround the blood vessels that go into the testicle, which can create changes in the environment, right? And so in those patients who don't have symptoms, like they're not uncomfortable from their varicocele or they're not having issues with fertility, do you still think there's value in fixing a varicocele to improve testosterone?
I don't. And I'll be honest with you. So there's 3 reasons to fix a varicocele. One, in a pediatric. In a kid, if you don't fix the varicocele, the side that has a varicocele, that testicle will atrophy, right? 2 is testis pain, and 3 is infertility.
Yeah.
So when Mark Goldstein first showed the improvement in serum testosterone levels, those numbers were about 85 nanogram per deciliter. I can't justify doing the surgery for 85 nanogram per deciliter.
Yeah.
And remember, it's the grade. So grade 3, the highest grade, tend to see the greatest improvement.
Yes.
So grade 1 has the least improvement, grade 2, grade 3. And if it's bilateral grade 3, you have the most improvement, but it's still about 85, 90 nanogram per deciliter. So it's just hard to justify taking someone back to surgery for that indication.
Yeah. No, I agree with you. I just think I don't want people to start showing up at the urologist office saying, increase my testosterone and do this surgery that has risks.
Right.
You know?
Yeah. And for a marginal benefit.
Right. For very minimal benefit. And I think the other thing, obviously, I think the reason that testosterone has gotten so much regulation is because of anabolic steroid use.
Yes.
I've done a deep dive in the literature on anabolics, and there's just so little literature on it, right? I mean, there's some, but it's really minimal because obviously people taking anabolics are not showing up to sign up for studies, right? Because they don't want to get in trouble.
Right.
So in modern day and age, I mean, if you look at the way bodybuilders use anabolics, they if they're, found a smart group of users, like they're pretty smart about it. They have really tried to hone this in a smart way. But I think let's go over what are the real harms of taking, whether it's exogenous T to supplement muscle gains or other anabolic steroids. What are the harms of it? And, when should we be worried?
So when you say anabolic steroids, we're looking at things that are not conventionally given. For example, if you look at testosterone enanthate, cypionate, these you can get commercially. We always look at something called the anabolic to androgenic ratio. Like it's a ratio. And most people want high anabolic with low androgenic. So the ones that we get commercially are a 1-to-1, cypionate, enanthate, anabolic to androgenic 1-to-1. The benefits of other anabolics like Anavar, oxandrolone, which is really a 10-to-1 ratio, nandrolone, which is 11-to-1 ratio. So they're giving a lot of anabolic with not a lot of the bad side effects.
Yeah.
And the anabolic mean muscle mass predominantly. So these are FDA approved. They have indications, for example. Like nandrolone is FDA approved for anemia in patients with chronic injury disease, right? Yeah. And if you have anemia with chronic injury disease, you can give it, but off-label, people use it for bone muscle mass and recovery of injury. Anavar has some indications also for muscle wasting. HIV patients can use it, trying to increase muscle. So I think the problem is that we don't have a lot of training. We didn't learn a lot of that. No. We don't have a lot of research, like a lot of trials. But, the bodybuilders are really good at this. Like they've really kind of figured it out. Anavar has some risk. It's hepatotoxicity. So you have to cycle it. You give them too much, you check LFTs. But I think a lot of it is that, we don't have a lot of training. We haven't done a lot of these kind of treatments. And typically we're in the business of getting patients who are hypogonadal into the eugonadal range to improve their symptoms, energy, muscle mass, libido. Right. And I think a lot of the anabolic steroid users are using it to increase muscle mass predominantly.
And I think the hard part is that they start these and now, there's actually so many young people starting these medications or supplements to do that because there's so much pressure to be very physically fit and appear a certain way. And they're very easy to access.
Yes.
And I think that the harm there is that we don't really know because as you mentioned, we just don't have the data on a regular healthy person using these medications over long periods of time. Right. And I think that's the real danger there. The other thing that comes up is that people get real side effects after stopping.
Oh, yeah. And I see a lot of times when they do stop, what happens is a lot of these patients need to be at a higher level to get symptomatic improvement for some reason. So they say, doc, you don't understand. When I fall below 1200, I don't feel right. And I don't know where the data is on that, but that's what I see in my practice.
I see the same
I
thing.
say, like, they're using a lot of T in high doses for a long period of time. You put them at 800, it's not, they don't feel it, so something's going on there. So when they stop also, they see a lot of muscle wasting also that can occur as well. But sometimes we have to stop because of fertility. That's an important point. So sometimes we have to stop because of fertility.
Yeah. And then a lot of times they can have sexual side effects.
Yes. And I do think that there's an inverted U. And the inverted U is going with estradiol and testosterone. I think that if the estrogen is too high, I think it can have a negative effect on sexual function and libido. And I think if this estradiol is too low, we can have a negative effect. We didn't talk about this, but besides libido, when the estrogen falls between 15 and 25 picogram per milliliter, there's a significant increase in bone mineral density going down, osteopenia, osteoporosis. That's the key number. So when you're treating someone with an anastrozole, and I say, look, just remember that 25. If you're going to put his estradiol at 15, you're putting him at risk. Right, you're putting him at risk for osteopenia, osteoporosis. And so be very careful. So this inverted U means some people should say, look, my libido is going down. The estradiol could be 112. We bring it back in a little bit. We manage it. They do better. I also think the same is with testosterone. I think if you have super high physiological levels of testosterone, I can see a negative impact sometimes on libido in some patients. So I think the body likes to be in the middle. It just it doesn't like to be low. It likes to be in the middle, centered. And taking someone in one way or the other can have an adverse event.
Yeah, I agree with you. And I think the thing about estrogen is there's a lot of misinformation, right? And people are like, I want as low estrogen as possible. So they start taking an anastrozole. They start taking these E blockers, they call them, right? And then they see this loss of libido and they just don't feel themselves. It's not even just libido. They feel changes overall where they just don't feel as great as they used to. You did mention that you rarely use anastrozole. So what would be the indication in your case?
Yes, there's a couple. So I tell patients, don't just throw anastrozole on there preemptively. Patient walks into a clinic, they give them the trifecta. It's testosterone, HCG, and anastrozole. They don't even check the E. They just give it to them. And the reality is that maybe you don't need it. My sweet spot for estrogen is 30 to 50 picogram per milliliter. I think patients do better. Now, it's a little bit higher than most people put it, but I put it there because I think that higher estrogen, people have better sexual function and libido. So 30 to 50. So let's say you're at 65. I'm not going to give you Arimidex 1 milligram a day. I'm going to either compound it at 0.25 milligrams or 0.5 and give you just one dose on maybe Monday and maybe later on give you one dose on Thursday. I'm going to slowly manage it to bring it back into the normal range and not shut you down. If I gave you testosterone and your estrogen went up from 30 to 45, great. You never needed the anastrozole in the first place. Right? So manage the anastrozole. Don't just throw it on there in the first place. So I think it's very important to realize that if a patient comes in with low T and they also have a very low estrogen level, be very ready to order a DEXA because that patient is at a much higher risk than just having a low T alone. It's that E that's your window for the DEXA, and they're going to be at higher risk for osteopenia, osteoporosis.
Yeah, that's super helpful. And I think it's also somewhat expected. If you have low T, there's nothing to convert into estrogen.
Right. That's exactly right. That's exactly right.
And it's going to go up when you give them T.
It's going to go up.
That's a normal expected response.
We expect that. The higher the T, the higher the E, the higher the T, the higher the DHT. So conversion to E is 0.3%, conversion to DHT is 6 to 8%. So if I increase the T, you better believe the E is going to go up. But there's certain things that can take the E away, like obesity. Right, so obesity is going to take all that E, take the T away also. The T is going to convert it into more E. They're going to aromatize as well, so you get even more E.
Yeah. You've mentioned some things that people get wrong, right? When they go to these T clinics and they get started on 100 different things or 3 different things in this case. What are other things we've talked about? Okay, so I'll start with the things we've talked about. Fixating on the numbers, starting on many different treatment options when you don't need it. What are some other things people get wrong when they start on testosterone or get started on testosterone?
Well, I think that there are still some fears. Some patients still think that they may get prostate cancer. There's no concern for prostate cancer now. AUA guidelines 2018, patients should be informed that there is no increased risk with testosterone increasing prostate cancer, and that was a strong recommendation, 2018. So it doesn't increase prostate cancer. There's another myth. If you open the package insert, it still today says that if you take take testosterone, it can make your urinary symptoms worse. And that is not true.
Right.
And in fact, even in the Traverse trial, we gave every single one of those men an IPSS questionnaire, a voiding questionnaire. And it showed that there was no significant worsening of urinary symptoms in those men taking testosterone over a placebo. In fact, there's not a single study that really suggests that giving testosterone makes urination worse, but there are some studies suggesting that long-term testosterone may improve urinary symptoms. So again, we should just be cognizant of the misconceptions of T, And then in terms of benefits, as many people don't realize that testosterone can actually improve your quality of life, like particularly diabetes, obesity, right? Bone mineral density, depression. We don't talk about depression. It's so important. I mean, you and I work at the VA, right? So I can't tell you how many veterans I see that come in with a diagnosis of depression or PTSD that have never had their testosterone level checked. And I'm not saying that we're going to treat major depressive disorder with testosterone, but I am saying that you should at least check it, because I'll give you an example. So in 2011, we had this big study. It was almost 850 men, and they had low testosterone, and we gave them the PHQ-9 questionnaire to look for depression. We found that 92% of men had some degree of depression, 92%. 17% had severe depression. We treated these men for 1 year, and severe depression went down from 17% down to 2%. And if they were already on an antidepressant, those patients also saw improvements in depressive symptoms as well, suggesting maybe some synergy.
Yeah.
So again, I'm not suggesting to treat depression with a testosterone, but it does help.
Yeah.
So if you have a man who suffers from depression, check the testosterone level.
Yeah.
That's the least you could do.
Yeah, and the other thing I will see in a lot of patients is this improvement in brain fog.
Yeah.
And I think it's hard. I think there are questionnaires that look at brain fog.
Yeah.
Or there's a question in the Adam questionnaire, asking about brain fog. But ultimately, I think that's, there are androgen receptors in the brain.
Yes.
It's not fully elucidated with the risk of dementia or other things, but it may come out that there is a benefit in that regard too.
I think so. I think it's an improvement in cognition. Now let's flip it for a second. Now let's flip it and say a man comes into you with low energy, low libido, depression, and you put him on testosterone replacement therapy. And you raise his level from 200 to 800. And he says, I still have all those symptoms. What's the next move? Screen him for depression.
Yeah.
It's the same symptoms.
Right.
Depression and hypogonadism share so many of the same, even weight gain, they all share a lot of the same symptoms.
Yeah.
So we're so fixated, urologists, they're like, okay, it's got to be T, right? And the psychiatrists are, it's got to be depression. So, as we fault them for not checking the T, we should fault us for not screening for depression.
Absolutely.
Right, same way.
Absolutely.
Yeah.
That's really a great point. We have to look at the whole individual, and I think that's really important. I think for anyone listening, if you're struggling with these symptoms, you may really be banking on that testosterone to help you. And if it doesn't, it's not that the testosterone's not working if the numbers are showing you what they're showing you. It's that there may be something else that we need to dig deeper.
Right.
Yeah.
And you have the other hormones. So the other mimicker is thyroid. Hypothyroid.
I check thyroid on everybody.
Yeah, because same symptoms, right? So everyone says it's got to be my testosterone. I say, no, we got to look for all the other variables.
Yeah,
Yeah.
absolutely. In terms of, you've mentioned that there's not any other hormone test, any other blood test that we can do that gives us such a beautiful view right into a man's health. So do you think there's a role for having a routine testosterone screening, or at least one at a younger age?
I think every man over the age of 40 should have an annual testosterone level checked. If every man who goes in for a physical every year gets their thyroid checked as part of a physical, the yield is so low, it's less than 10% at best. The testosterone is a much better indicator of your overall health as opposed to
and probably a higher yield.
A much higher yield.
Yeah.
And many people will argue that sometimes the symptoms are because of the delta. If you started out at 800 and today you're at 350, you probably or could feel less than someone who started out at 600 and today is at 350. The delta may be an issue. So I don't know your delta if I never checked a baseline.
Yeah.
Right? I don't know your delta, right? So it's very important to check these T levels every year in every man over the age of 40. Now, you said something very important, like, this is a marker. And you and I do a lot of men's health. That's what we do. And testosterone, I think we both agree, is probably the best indicator of a man's overall health. But there are two other indicators that are fantastic. One, a semen analysis. I can tell you so much about a man's health with just a semen analysis. And the second is erectile dysfunction.
Yes.
A man walks in with ED, I can tell you a lot about his cardiovascular, diabetes, depression. So when what we do, the three markers are testosterone, semen analysis, and a diagnosis of ED, I can tell you so much about what is happening today and what's going to happen
if you do nothing.
if you do nothing.
Right.
Right? And that's really important.
Yeah.
Yeah.
So important. And I think that's why, I mean, this part of the reason I do what I do is because what we do, people think it's no big deal.
Yeah.
Like it's just sex,
Yeah.
right? But what we do, sexual health is health, right?
It's
and
health.
we are looking for issues that can undercover so many. I see so many really healthy looking guys.
Yeah.
They come in, they're very physically fit, they are high performers in their job, and they have low testosterone and they have high cholesterol. And they didn't know they had high cholesterol until they came in and saw me and we checked their cholesterol because they don't even need to see a PCP. They think they don't need to see a PCP, right? And they don't get any blood work done. They're like, I'm fine, I'm healthy. They finally come in because guess what? Now their erections are a little less robust and they're not consistent. And so that's what brings men to the doctor. And this is an opportunity, right?
Yes.
And I think for all primary care doctors and doctors who aren't specialized in sexual medicine, that's an opportunity.
Yes. So you are so correct. I say this all the time. Sexual health is the gateway to a man's overall health, particularly for young men. So if you look at men between the ages of 18 and 40, less than 45% of those men go in for a routine exam. So I can think of myself when I was 30, I wasn't going to go check my blood pressure annually. I wasn't going to get a hemoglobin A1C. You're 30, you kind of do your thing, right? But if a man develops ED, he's in my office tomorrow morning, first thing, right? Now the question is, do I have an opportunity? Do I have an opportunity to diagnose diabetes, cardiovascular disease? Because if I diagnose it today, as opposed to when it would have been diagnosed when he was 40, we call that area under the curve 10 years or less damage. And that could change the trajectory of his life, right? You absolutely could. And the mistake, this is the mistake that a lot of people make, is handing him the Viagra and saying goodbye.
Right.
That's the mistake,
Yes.
right? That's the lost opportunity, right? So it is absolutely crucial that when a man walks in with ED to screen for at least two things, cardiovascular and diabetes. Big study out of St. Louis, almost 2 million patients they looked at coming in for ED. 30% of those young men, 18 to 40, had prediabetes or diabetes on the day they were diagnosed with ED. 30%. That's a big deal. I mean, that's you can find it right away. And, cardiovascular disease, the data just as well as I do. 15% of men in 7 years will have a heart attack or stroke from the onset of getting ED. So there is an opportunity to do this. I want to give you a really good study that really impacted me. There was a study that came out of Greece, and they looked at these men, and they had ED, and they came into the clinic, and they did a stress test or an echo. If it was positive, they would do an angiogram. And there was just 50 men who walked in randomly for ED. And they ended up doing the angiogram, and 20% of the men had either 1 vessel, 2 vessel, or 3 vessel occlusion on angiogram, right? So I thought to myself, that's kind of significant. 1 out of 5 guys that I see in my clinic actually have occult cardiovascular disease with some occlusion in the heart. And wouldn't this be the opportunity to change the course, right? That's very important.
Yeah, absolutely. And honestly, I think it's a big motivator for people. If I say, hey, you might get heart disease, so you should work out. People are like, okay, I'll get to it. But if I'm like, hey, if you start, and this is your study, if you start exercising 150 minutes a week, you're going to see improvement in your erectile function as good as taking a Viagra. Like that is a huge motivator.
Huge
for people.
motivator. And reversal of erectile dysfunction. So what you just said was so important. Think about this. If you broke your leg today, I have 2 options. I can fix your leg, or I can give you Vicodin. Because if I give you Vicodin, you'll still be able to walk. Right? But eventually the Vicodin will stop working and you'll have to do something about it. The way we treat sexual dysfunction today is Vicodin. That's what we do. We come in, Viagra is just Vicodin, right? It's just, I give you the Viagra, and as time goes on, you go into injections. As time goes on, you go to a penile implant, right? Viagra is just Vicodin. But what you just talked about was exercise, lifestyle modification. That actually reverses erectile dysfunction. And that to me is far more powerful. That's fixing your leg, right?
Yes. And I think the important thing also that you pointed out, Viagra is going to stop working, not because the medication stops working, but because you get sicker.
Absolutely. I said that because the disease progressed and now the Viagra can no longer hold the fort. That's what I tell them, right? It's not because of Viagra, you became resistant to Viagra.
Yes, which is what a lot of people think, like, oh, it's just going to stop working.
Yeah, it's not resistant. Your body became worse. So that's why one of my favorite drugs is actually daily Cialis. I think daily Cialis, FDA approved to help with erectile function, FDA approved for BPH, FDA approved for pulmonary hypertension, and it protects the endothelium, the lining of the blood vessels. Kloner last year published a paper showing 13% reduction in MI in those men taking daily Cialis versus not, which is a big deal. So I tell a patient, okay, your heart, your penis, and your prostate all benefit from one pill, and it's cheap now. You can get it cheap. Yeah.
Yeah.
Why wouldn't you? I mean,
Yeah.
there's side effects, so we can, you talk about those, and you don't want to take it with nitrates. But again, the benefits are really significant, particularly on prevention.
Yeah.
If you take this today, if you were going to get ED at 65, you may now get it at 70. I can shift the curve because I'm keeping the tissue healthier longer by the daily PD5 inhibitor.
Yeah, I love it. I think it should be in the water. I joke, and I can already hear the comments being like, oh, you guys are paid off by Big Pharma. We are not.
Yeah.
And number one, these medications go through rigorous clinical trials. And I think that's the difference. People are very willing to take a supplement that has very minimal data, no data, and is not regulated. And when people pour millions of dollars into studying medications to make sure they're safe, they're efficacious, they do what they're going to say they're going to do, and they compare them to a sugar pill or a placebo, that is why doctors like to talk about these medications, because they work and they're safe. And we can say that with confidence. And so I just want to put that out there because I think it's great and I think it works really well. And I think if you are starting to notice any detriment in your erections, I think there's a real long-term benefit, as you mentioned.
I agree 100%.
Yeah. You mentioned semen analysis, and I want to talk about that. Why is a semen analysis a good barometer of overall health?
Yeah, so semen analysis is important for two things. I want you to think about what's happening today and what's going to happen in the future. Let's divide it up. So semen analysis today, there was a really nice study by Androni Salonia who showed that men who have lower semen analyses, worse semen analysis, tend to be more unhealthy. That's true. Healthier people are more fertile, period. Darwinism, survival of the fittest, right?
Yep.
So you pass on the genes. So healthier people are more fertile. If there's a decline in your semen analysis, many times it's been shown that you're more unhealthy. One of the biggest culprits is obesity. As you become healthier, semen analyses should improve. That's number one. Number two is what's going to happen in the future. So a good friend, your friend too, Mike Eisenberg, had a wonderful study on semen analyses and basically showed that if you have a decreased semen analysis today, you're more likely to have ischemic heart disease, diabetes, alcohol abuse, drug abuse in the future, right? I think ischemic heart disease was up to 50%. I think diabetes was 30%. So if I told you, hey, your semen analysis today is poor, you have a 50% more likelihood of having ischemic heart disease in the future. Semen analysis today, I know you're only 30 years old, is poor, 30% more likely to have diabetes, and more likely to suffer from drug abuse and alcohol abuse in the future. So this is what's coming in the future. I would take that very seriously. So what's going to happen in the future? Now, let's even flip it even more. Let's talk about cancers, okay? So many studies showed that if you have a poor semen analysis today, much more likely to have testis cancer. Jay Rahman study, right? Significantly higher number of testis cancer today. And what's going to happen in the future? Tom Walsh, 2.6 times more likely in the future to have high-grade prostate cancer, right? So wait a minute, I have a poor semen analysis today, 2.6 times more likely to have a high-grade prostate cancer in the future. I'm going to pay attention to my PSA and my prostate, right? So it's a great window into what's happening today and what can happen in the future. And what's nice is it's modifiable, which means that if I improve my health, my semen parameters should improve as well, right?
And now getting a semen analysis is easier than ever.
Yes.
Right? There's these at-home kits. I mean, they weren't around when I was in training, but they are here now, and they're really, really helpful.
Yes, they are.
They make it more comfortable, I think, for the patient.
I agree.
Why drug abuse and alcohol abuse? Why would having was there a hypothesis as to why that happened?
I did not see the hypothesis. It was just listed as the 4 main things that would occur in the future.
Interesting.
He followed this. It was a database.
Yeah.
And he followed these patients and he found higher rates of ischemic heart disease, diabetes, alcohol abuse, and drug abuse. I don't know about why the drug abuse and alcohol abuse.
Maybe there's some mental aspect to...
Yeah, or fertility, having some kind of depression or anxiety.
Yeah,
because we do know that patients who are infertile can have more higher incidence of depression and anxiety due to the infertility.
Yeah.
You know?
Absolutely. Let's move back to erectile dysfunction.
Sure.
Are you feeling in a rut in the bedroom, wishing you had the kind of sex life you could brag about? I've spent years helping patients and creating content for people all around the world to improve and optimize their sex life. Today, you can get my knowledge for 100% free with my new ebook called Better Sex, Better Life. In this ebook, I review my top 10 tips for improving your sex life, all from the comfort of your own home. All you have to do is go to renamalikmd.com/morepleasure to download it for free today. You just recently published a paper on hyperbaric oxygen and using that to improve erectile dysfunction. I didn't even know, but apparently celebrities like buying hyperbaric oxygen chambers in their home, which was like surprising to me, but I guess there's a benefit. So explain why that would be helpful.
Yeah, so I think this whole thing started from this movement in our field on regenerative therapies. We just talked about Vicodin, and no one wants the Vicodin anymore. They want you to fix the leg, right? So if you want to fix the leg, maybe there's ways to do it. The biggest ones are PRP, Shockwave Therapy, and stem cells, right? Those are kind of hot right now. So if you look at other regenerative therapies, one of them may be hyperbaric oxygen. Hyperbaric oxygen it always amazed me how you put someone who has a diabetic foot ulcer inside the machine and the ulcer improves, like the healing regenerative properties. Now, I just want to be very clear. Our study that we published was only on 5 papers. It's not mainstream, but there's a plausible mechanism. That's all. There's a plausible mechanism. In our paper that we published, if you went in for the hyperbaric oxygen for another reason, like your foot or some kind of cystitis, the change in IIEF was about 5, improvement in erectile function scores. If you went in strictly for erectile dysfunction, the change was almost 10 on the IIEF, so it's pretty significant. The important thing is this. Anything that induces trauma to the body tries to heal it. That's why shockwave therapy works well, because you're basically causing a trauma, shock to the penis. The body says, hey, there's something going on here. It's something bad. We're going to go fix it. We're going to bring in some new blood vessels, some growth factors, some stem cells. We're going to fix it. Well, hyperbaric oxygen, I believe, has the same thing. There's something called air brakes. So if we take the atmospheric pressure, let's say to 2.8 or 2.9 atmospheres, and then every 60 minutes or every 90 minutes, or you take it down to atmospheric pressure, then what happens is the body may think it's hypoxic, even though it's not hypoxic, and it starts kicking out growth factors and things to help heal the body. So that's a plausible mechanism. The problem is that a lot of the home hyperbaric oxygens, it's not enough. You have to have higher atmospheric pressures, and those are typically done in a hospital setting, right? You have to bring in the oxygen line. It's expensive. I don't want people to think to go out and start doing hyperbaric for ED. It's just something to look at. It may have a plausible mechanism, but much more research needs to be done in that area before it even becomes mainstream.
Yeah, because I was surprised. They're very expensive, at least the ones in the hospital.
Yeah, they are.
Exceedingly expensive.
We looked at 2 of them. So we looked at Seacrest because it's a hospital grade, and they're about $300,000 for what we call a monoplace chamber. It means one person go in. A lot of the other clinics, one's called the Aviv Clinic, where there are many patients in a room, and then they turn on the machine and the atmospheric pressure goes up. But the monoplace chambers are about $300,000, but it's very expensive. I looked into this. I have to get the oxygen to come all the way in from the main hospital line. You have to get a build out. It is pricey. So some people say, well, I got the home version, but those home versions go to 1.3, 1.4 atmospheres, and it's really not enough to see a significant improvement.
Yeah. And let's talk a little bit about the other options. So shockwave therapy, we have a lot of data on shockwave therapy.
We do. And we have randomized placebo-controlled trials, right? Which is pretty interesting.
Yeah.
And I think, in 2018, we said that it should only be considered investigational. The SMSNA currently is looking at the data again to see if there's more data to support it. The Europeans have now put in their guidelines that it will be an acceptable modality of treatment for ED. In the US, we don't have it in the AUA guidelines or even in the SMSNA position statement yet, but we're looking at it because now there's been 7 more years of data.
Yeah.
And but I do think there may be some role for this. We are seeing patients. You just have to use the right machine. I think that the electrohydraulic, electromagnetic are much more effective. I don't find as much utility in the pneumatic machines. I don't think they work very well, but the electrohydraulic, electromagnetic do work. And I think that it's very important that the patient knows what kind of machine they're using, because most of the time they don't, right? And they just go in and they pay their money and they hear the click and they think it's going to help. And the sad thing about erectile dysfunction is that we have a 30 to 40% placebo rate, which means if you give 100 men a sugar pill and you tell them they will have the best erections of their life, 30 to 40% will have the best erections of their life. Like it's such a strong placebo, sex is, right? And so even if you had the machine that was not as effective, you're still going to get people to come back, at least 30 to 40% of them, because they feel like it's doing something. So you got to make sure you're using the right machine. Yeah. What I like about the Shockwave, so we did the first stem cell trial in the United States for ED. We published it, and we used a machine called tissue genesis. We did liposuction, put the patient to sleep, and we put it in a machine called an accelerator, and it gave me back 37 to 50 million stem cells, and we injected it. And it worked okay. It wasn't sustainable. After 6 to 9 months, I could see the level fall off, and it didn't work it wasn't sustainable. And I couldn't justify bringing people in every 6 to 9 months to intubate them, put them to sleep, do liposuction, and do it over and over again. But to this day, what's surprising is we still don't have one single randomized placebo-controlled trial with stem cells. That would be the easiest placebo-controlled trial to do, not been published, right? That's interesting. But what I love about the shockwave is when you induce shockwave trauma to an organ, you bring stem cells to that organ, right? So instead of me going to get your stem cells and try to put them in the penis, why don't I just use shockwave and bring the stem cells to me? Right?
Super safe,
it's easy, less invasive. So that's why I feel like you get the benefit of shockwave plus the benefit of stem cells with just by doing shockwave.
Yeah, and the thing I tell patients is like shockwave, we know that it works in a good percentage, like 60 to 70% of people with mild to moderate ED, but it's the long term that we know that at 1 to 2 years it's going to drop off. So there probably needs to be a maintenance.
A booster,
Yeah, and so I don't know that there's a clear winner in terms of what that maintenance should be. So
nobody knows.
I'm curious.
Nobody knows.
Yeah, what do you
we
do?
don't know either. So when we finish it, we offer one shockwave treatment once a week for 6 weeks or twice a week for 3 weeks. And then at 3 months, we reevaluate and decide if they need a booster. And sometimes we evaluate at 6 months and see if they need a booster. And so it's kind of based on when we notice there may be a detriment. But I think it's really important to counsel the patient appropriately. You do not want to tell them, hey, if you do this, your erection is going to be much better. Say, no, this is investigational still. You know, there's a chance this will not work. And so I just want to make sure, Mr. Smith, you're aware of that because sometimes it's oversold. And that's a problem.
Right. Exactly. I think it's, I mean, I probably counsel very similar to you in that regard, but I think it is really important to not have like, this is it, this is going to be perfect, everything's going to be great, I don't need medications, everything's going to be perfect, especially when you have very severe erectile dysfunction, because it's unlikely to work in that population. And then, I think, as you mentioned, it's really important to know that you're getting a focused shockwave treatment, not a radial shockwave treatment, because they, to the average person, look the same.
And sound the same. They have no difference.
And so if you don't know, you will be getting basically a massage of your tissues.
Expensive massage.
Yes, very expensive. Are there other uses for shockwave? I know there are currently some investigational uses.
So we have the only clinical trial in the U.S. looking at shockwave to treat infertility. So we have an IRB-approved protocol to shockwave the testicle. And so in this trial, I took patients who I've done a microtesty on and that have failed, and the only option is adoption or donor sperm. And that population, then we will do a shockwave to the testicle.
And a microtesty, just for audience.
For sperm retrieval. It's a very invasive sperm retrieval. It's kind of like the last resort. And if you don't find sperm on the microtesty, then I say, okay, there is a trial that we have that we're doing. And we will apply shockwave to the testicle, and then we will offer a free biopsy to the patient to see if we can recover sperm. So far, what's very interesting, what we're seing, is that the 17-hydroxyprogesterone goes up significantly. So that's interesting.
So your intratesticular testosterone
is going up. So I'm hoping that will correlate with increases in spermatogenesis. But so there's a hope. So this is the only trial looking at that. I didn't want to take patients who are oligospermic because I didn't want to make them azospermic. I didn't know what was going to happen. So I'm taking like patients who are no sperm, failed a micro, no other option. Okay, then we take this. So that's an indication. Prostatitis has been looked at. BPH is now being looked at for shockwave as well. In females, they're also looking at for vestibulitis as well. I mean, there's a lot of different applications. Pelvic floor dysfunction. I still think the Peyronie's, just be careful. It is helping for pain, but there's the data still is not, that's been published, is not really convincing for shockwave for Peyronie's improving curvature. Right. So I think that's important because there are claims being made out there.
And again, all these are investigational, but I think promising and exciting that potentially some of these will pan out.
But more studies need to be done, but it's interesting. We're making progress. This is the quest for regenerative therapies. Fix it. Don't just put a Band-Aid on it. Fix it. And this is where we're headed. One other regenerative therapy I think that's going to be hot is radiofrequency. So I think it's interesting because radiofrequency has been around for a long time. These machines typically are used on the face to tighten the collagen, right? So it's type 1 and type 3 collagen. And most of the regenerative therapies I'm talking to you about today are really good at increasing the inflow, helping with arterial insufficiency. But the number one cause of ED in the world is venous leak. So how can we fix venous leak? Well, if you think about the tunica albuginea and the wall, it's made out of type 1 and type 3 collagen. And as patients get older, that wall, I call it the drum, gets more and more lax. So it's harder and harder to push the muscle against the wall and compress the veins. So you get venous leak. But theoretically, if you could tighten the collagen and tighten the drum, and then you push against, you should be able to prevent venous leak.
And have good inflow, obviously.
And still having good inflow, because remember, inflow is not really the problem most of the time. It's really the outflow.
Yeah.
And so if I can tighten the drum, maybe there's one study out of Israel, OMED, which had a home device called Vertica. And Vertica essentially in the first month had an 8-point increase in IIEF scores. And it was sustained all the way to 3 months. It wasn't placebo-controlled, but we're doing the placebo-controlled trial now. But it was 26 men and basically saw a significant improvement in erectile function score. So maybe there's something regenerative. And today we're discussing all the maybes, which is interesting because these are all the possibilities.
Yeah.
But I think keep your eye out for radiofrequency.
Yeah, and it's an at-home treatment.
That one's an at-home. Yeah,
That's
but
exciting.
others are looking for office space. But any way you can do it. But the reality is, if it works on type 1 and type 3 and it tightens the collagen, let's say for the face, it should work on type 1 and type 3 in the penis. I'm suspecting it's a plausible mechanism. Let's see.
Yeah, I think so. I mean, because it's not like the tunica's that far.
It's not that far.
Yeah.
And it becomes we know that collagen becomes lax as we get older. We see it everywhere in our body.
Yeah.
Right? If you could tighten the collagen, which has been already been shown to be other body parts, maybe you can help with the venous leak.
Yeah, that sounds really exciting. What about PRP?
PRP, I think, is gaining more interest, but the only issue is out of the gate, it came out bad because what happened was the claims were through the roof. The P shot, the O shot, 1,500, 3,000, and there was no data till 2018, right? And the claims were coming out early 2010. The first study was Ryan Terlicki's 2018, 5 case reports of some patients that got a little better with PRP. That was the first study.
Yeah.
Now, subsequently, there have been studies out of Europe, randomized placebo-controlled trials, randomized placebo, showing there was some benefit. The big study out of Miami showed there was no benefit. So I think it kind of goes back and forth. So there may be some benefit. We just need more data.
Yeah. I think it's pretty early for
Yeah.
that. What about Botox?
So Botox has a really good plausible mechanism. So think about what Botox does. It relaxes muscle. Now, it typically relaxes skeletal muscle, and the penis is smooth muscle, but it does have some relaxation on smooth muscle as well. Botox has also been shown to release nitric oxide, so it can help with the nitric oxide release, and it can actually decrease the sympathetic tone. So if something has a high sympathetic tone, it can relax it. So it has a benefit of all three. There was a randomized placebo-controlled trial looking at Botox 50 units, 100 units placebo, showing a significant improvement in those patients who got the Botox over placebo. And if you got the 100 unit, the highest dose, that had the greatest longevity up to 6 months. So there may be something into it. Again, it's off-label, but there may be something into Botox and ED.
Yeah, I've been using it on a handful of patients.
Good.
I will say that they don't say it is very robust, but they notice an improvement.
Okay.
So I would say they're not like, oh, I don't need to take my tadalafil, but it's better. It's more rigid.
Yes.
And they come back because they like that.
Yeah.
And there is a potentially small increase in flaccid length because you're relaxing the smooth muscles. So I think while they haven't admitted it to me, I think they like it.
Yeah. And I think it's it's relatively safe. And the only thing you think about is that, they do have to come back as Botox wears off.
Right.
So, okay, fine. So they come back, but some patients don't mind.
Yeah. Yeah. And again, it's investigational.
Yeah.
We have very small studies, but we have some randomized data, and they did it on patients with severe ED.
Yeah.
And they saw like a 30% improvement in those patients, or 30% of people who didn't need an implant who were going to get one. So I thought that was pretty impressive.
That's pretty impressive.
Yeah. You talked about nitric oxide.
Yeah.
And I think a lot of people hear nitric oxide is important for erections, and they go and get these nitric oxide boosters.
Yeah.
And to my knowledge, there's really no data on nitric oxide boosters as supplements. Anything that you found in your research on that?
Yeah, I'm really reticent about a lot of supplements. So this is the scary part. So you and I can make a supplement today and go put it on the GNC shelf, and no one's going to have to check it for safety or efficacy. Great study that came out recently looking at the top 50 supplements for the testosterone boosters. Only 25% of those even had data on efficacy. So I can't tell you if it's safe. I really can't tell you if it's effective, and neither can you. So I tell the patients that. So I don't know, right? So I get a little nervous. I'm okay sometimes using amino acids like arginine, carnitine, citrulline.
Yeah.
And these are just basic, simple amino acids. And if you remember from biochemistry, if you put arginine, carnitine, and citrulline in a petri dish, those are the three things that equal nitric oxide.
Yeah.
And each one independently has been shown to potentially help with sexual function, or ED.
Yeah.
So I say, look, this could help you. Nitric oxide goes way beyond just ED. It's the heart, it's the lungs, it's everything, but it could help you. But I don't want you to put your hand on it and say, this is going to change everything. It could potentially help.
Yeah, I agree. I'm in the same mindset. Yeah. The other thing I think that we just need to touch on briefly is there are certain medications that have, while don't happen to a large number of people, but have some really serious sexual consequences. Yes. And those are antidepressants, finasteride, and new to me, which I learned probably in the last few years, was tretinoin.
Accutane, yes. Yeah, let's talk about that. So, you and I were taught something in medical school. We were taught that when we give someone finasteride, it blocks the conversion from testosterone to dihydrotestosterone. And that's all we were taught. But we weren't taught the whole story. Because the reality is there are 6 pathways that are blocked, and those 6 pathways go on to other pathways. So it's a total of 12 pathways. The other 6 are neurosteroids, and one of them is implicated is allopregnanolone. So allopregnanolone is for anxiety and depression. The reality is that many patients who take finasteride, many of them have reported once they stop finasteride, they have persistent adverse symptoms, whether it be ED, anxiety, depression, muscle wasting. So it's been documented. Now, I believe that it's a real syndrome because many of those patients that we see, I did a large trial post-finasteride, 25 patients with finasteride, 25 did not. In my trial, 2 patients committed suicide. It was devastating. It was absolutely devastating. I say to patients, let's say you don't believe that finasteride causes post-finasteride syndrome. Let's say you don't. But what you cannot deny is that when those patients are coming in, they are suffering from something, right? As a doctor, they're suffering, right? Yeah. It's your moral obligation to help them in any way you can because they're suffering. Number 2, let's say tomorrow I told you that there was a drug called drug X. And I said, Rena, did you know that when patients take drug X, they're more likely to commit suicide? Okay? I don't care whether you believe drug X is the cause, not the cause. I just tell you that when patients take drug X, they're more likely to kill themselves. Shouldn't you take that seriously? Yeah. Shouldn't you say, wait a minute, I don't care whether you believe it's the drug or not the drug, but people are killing themselves more likely if they take this medication. We should take it seriously. I believe it. I know I'm the minority, but I think that it is a real condition, and not everyone suffers from it. So, we did 2 big trials. I think patients have a genetic predisposition. Millions and millions of people take finasteride. Yeah. They don't all suffer from post-finasteride syndrome, right? But there is a subset that do, and I do think that it is an element of the drug, right? Now, there's SSRIs that can do it as well. This is post-SSRI syndrome. Some people call it PSSD, post-SSRI sexual dysfunction. Interesting thing happens here. You can get erectile dysfunction. Some men complain of premature ejaculation when they stop the medication, and this is persistent. Muscle wasting can occur as well, and it's due to believe to changes in the serotonin receptor, issues with something going on with serotonin. I don't see that as much as I see in my practice post-finasteride syndrome, but people have documented PSSD as a real condition. And then the last one is with Accutane. And I'll be honest with you, I've read about it, but I've never had a patient who've taken Accutane and had persistent sexual dysfunction, but I have heard of the condition.
Yeah, I've heard of it too, but I haven't seen it. And I think, you brought up a good point. It's like we need to believe patients. Yeah. And I think that's the thing that I think people don't feel heard, right? When they're suffering from something like this, and like, I took 1 pill and I felt like I had a patient who was like, I took it once and I have these symptoms and they won't go away. Yeah. And whether they are caused by that 1 pill or not, they're his symptoms and they feel them.
Right. They're coming in and they're suffering. Yeah. They're suffering from something.
Exactly.
So you got to take it seriously.
Absolutely. Yeah. In this select population, it's sort of difficult to treat. What is sort of your, what works in this population?
So the first thing is to manage expectations. When they come in, I say, look, I don't have a cure for this. I don't. I can do things that may help mitigate the symptoms, right? Many times with post-finasteride, what you do is time. Time helps a lot, right? So that may help, but I can use things. I try to stay away from a lot of drugs that will affect the brain also, or can affect, because a lot of the patients don't want to take medications because they feel that that's how they got in trouble in the first place. Right. So, but sometimes if the testosterone is low, I may use HCG to raise the natural endogenous testosterone. Daily PD5 inhibitors like Cialis may be effective. Sometimes I feel like my hands are tied. I don't know what else to do. I mean, I get sex therapy, but it's limited, but we try to mitigate the symptoms right now.
Yeah. Yeah. I mean, I think that's the approach. It's very challenging. I wish we knew more, but it is a small subset of people and we need more investigation.
Yeah, I agree.
What are you working on now that you're really excited about?
I'm excited about SexBand. I want to talk about it. It's, I am excited about changing the way we think about sexual dysfunction and taking a much more proactive approach. And I got the idea because when I started going on some podcasts and listening to everyone in the world is talking about lifespan and health span.
Yeah.
That's it. Lifespan, health span, longevity. I said, okay. And you and I, Rena, we both hope that our health span lasts as long as our lifespan. Right?
Yeah.
I do. Right? You do. It's like, so if I am going to live till 80, I don't want to be healthy till 60.
Yeah.
Now let's look at the reality. The average lifespan in the United States is 77 years old. Women are 79, men are 75. The average health span in the United States, according to WHO, is 67 years old. So for 10 years, most of us will have some disability before we die. And if you look at the CDC criteria, they talk about how long you will live without having a disability that will impair your ability to do activities. It's 64 years old. It's even younger. So everyone's bragging, every country is bragging on how they're improving the lifespan. In 2050, our lifespan will be 80. That is the dumbest thing. Do not increase my lifespan. All you're doing, if you don't increase my health span, is increasing the number of years I will live in torture, right?
Yeah. So, and use a lot of resources.
And a lot of resources, right? So increase my health span. Well, the same thing applies to sex span, right? Sex span is the portion of your life where we have the ability and the desire to engage in satisfying sexual activity. And most people want their sex span to last as long as their lifespan.
Yeah.
Right? Let's be fair, right? Most people do. And if you do want your sex span to last as long as your lifespan, you need to be proactive about it, just like your health span.
Absolutely.
Right? Be proactive about prolonging your sex span.
Yeah.
It's very important.
Yeah.
And so when you get the ED or a woman gets sexual dysfunction, it's unfortunate. We can treat it, but I wish I'd known 10 years earlier, so we would put you on a program that we wouldn't be here in the first place. And so that's why we talk about, when patients come in, there's no just giving you Viagra. It's what are you going to do for your diet? What are you going to do for exercise? What are you going to do for sleep? What are you going to do for stress reduction? Let's talk about your program. You meet me 50%, halfway, right? That's the program, 50-50, right? And that to me has become much more exciting than another Viagra pill.
Oh, absolutely.
It's just become much more exciting.
Absolutely.
Yeah.
100%. And we didn't talk a lot about female sexual dysfunction, but there is so much there that we can't measure erectile dysfunction in women because we don't measure clitoral tumescence.
Yes.
Women don't always know when they have clitoral tumescence. They don't always see it. And they're obviously having it throughout their night and things of that nature when they're aroused, but they don't know.
Yeah.
And so I'm certain that it's very similar, right? When a woman starts having issues with clitoral tumescence, that 15 years later, she's at higher risk of, getting a heart attack.
It's already, some data has already been shown.
Yeah.
So there's data to show that if a woman will increase cardiovascular disease, she's much more likely to suffer from female sexual dysfunction.
Right.
And I think the analogy is more arousal disorder, right? Because arousal disorder for her is identical to erectile dysfunction in a man, and they both are a vascular condition, right?
Yeah.
And studies have shown that if she has if the greater the stenosis and coronary, the greater the FSD. But if you treat her and put her on a cardiac diet, if you improve her cardiac function, you significantly improve her sexual function as well. They're linked. It's no, men and women are not that different.
Right.
Let's be fair.
Yeah.
Right. So the cardiovascular risk is going to be the same, I think, in men and women, and it's the same. But the problem is we have such little data on women, right? It's a fraction of what we would spend on men for ED, sexual dysfunction studies. The first drug ever, that came out for women didn't come out till 2015, ADE.
Yeah.
Did not come out till 2015. And before that, if you and I walked into Walgreens, asked for all the drugs for women, zero. Nothing for sexual dysfunction. 30, 40 drugs for men, zero for women, right? Now you can walk in, you can get ADE. She takes it every day. It's FDA approved to increase her libido. You can walk in, you can get Vyleesi, an injection, FDA approved to increase your libido. Okay, so now we're talking. We're starting to get some movement, but it's still so far behind what we have for men.
Well, I think the issue also is arousal is very difficult to measure for a woman, right?
Yeah.
She may just be like, oh, my libido's not that there. I have a lot of stress in my life. I have growing children. I have aging parents.
Yeah.
And it's not as easily measurable for the average woman to say, is this something that's really wrong? Or is it just that I don't have a good libido? Like, is it really a problem with arousal?
Right.
Or is it just that my desire is not there?
It's not as obvious as an erection, right? It's not that so that's very important. But I do think that if a woman suffers from female sexual, this before components, low libido, arousal, orgasmic dysfunction, or pain, she has any of those, and she's bothered by it, she should seek therapy. 48% of women, up to 48% suffer from this in the U.S., and only 9% seek therapy. Why? Because they don't know where to go.
Yeah.
I call it suffering in silence. They don't know where to go. And the most common treatments are lubrication, right?
Yeah.
But that's not really the best way. Even it does help, don't get me wrong.
Absolutely, yeah.
But how about vaginal estrogen? How about putting her on testosterone? How about some estrogen? And maybe getting her some AD, Vyleesi. Let's treat her.
Yeah.
You know what I mean? But just saying, here's some lubrication and you'll be
Drink
fine.
a glass of wine.
Yeah. That's not the way to treat her.
No.
So we have to be more systematic and really, really think about how we want to improve women. I call this the couples disease. Let me tell you why. You know, and I know Irwin Goldstein very well. Irwin Goldstein did the most amazing study. He took 220 men with erectile dysfunction, and he gave half the men Levitra, which is a medication to help with erections, half the men placebo. And he gave all the female partners at home the FSFI, the Female Sexual Function Index questionnaire, to see her sexual function. He said, I don't want to meet her. I don't want to talk to her. Just give her this questionnaire at the beginning of the study and give her the questionnaire at the end of the study. And what they found was if a man took Levitra to help improve his erections, the women at home had a significant improvement in all 6 domains of the FSFI. If he got placebo with no improvement in erections, she saw no improvement in the FSFI. So what am I telling you? I can treat her and never have a meeting her. I can treat her just by treating him. And the reverse is true. We show by treating women with testosterone, men will start to have a significant improvement in their erectile function, right? It's a couple's disease. You can't just give them Viagra and not ask about who he's going to have sex with at home,
Absolutely.
right? I mean, that's a big mistake. A story I have to share with you. 2007, I finished my fellowship. I was so proud of myself. I was able to get these men those amazing erections, amazing libido. And one day a woman called me and she was so upset. She said, everything was great until he met you. We fight all the time. He wants to have sex. I don't want to have sex. And you've ruined our marriage, right? And I thought to myself, what is she talking about? But she's right. You don't increase one libido without increasing the other. Leaving both libidos low is perfectly fine.
Yeah.
It's okay, right? Raising both are fine, but you don't raise one without the other, right? And so it's a couple's disease. So if you're treating the man, talk about the partner. Treating about the woman, talk about the man. Treat them both. You're much more effective by treating the couple.
Absolutely.
Yeah.
Absolutely. And I think that, talking about women, I think there's also like a societal stigma, right?
Yeah.
Women are caretakers. So they don't look after themselves. They don't necessarily vocalize that they're having issues with sexual function. They may actually feel embarrassed by it. In fact, I just saw a reel the other day where there was these young girls talking about oral sex, and the girl goes, well, I feel guilty when my partner gives me oral sex. And I was like, what? Why? Like in my head, I was like, why would you feel guilty? Like this is a pleasurable moment for both of you. And I realized like this is really how different men and women. I've never heard a man say, I feel guilty when a female gives me oral sex. Never, right?
Yeah.
And in a heterosexual relationship. And so I just think there's also this like, oh, my needs and my sexual pleasure are just not that important.
Because it's stigmatized.
Right.
It's stigmatized in all facts, at all levels. And even sexual dysfunction is stigmatized.
Yeah.
And you have to destigmatize
Absolutely.
sexual.
So I think that's a huge part of it.
It has to be considered a normal.
I mean, there's so many products to make women smell better, clean up, whatever nonsense that is unnecessary, right? Like we are dirty, right? And so I think it all comes from marketing, from media, from everything. And I think it's not just that we didn't have the tools; it's that there was not as much of a push for the tools because people were like, oh, how could I talk to my doctor about this? Yeah. And then when they finally did talk to their doctors, because they were now in a more vocal generation, then their doctor's like, have a glass of wine, and like, they were like, well, this sucks. So anyways, I think so for all the men listening, make sure your wives feel empowered to talk to somebody and find someone who's an expert in sexual medicine. And same thing for the female partners who are listening, make sure your partner's also treated.
Yeah, I agree.
So we end our podcast with some questions. They can be about urology, they cannot.
Yeah.
What's something you know now in your life that you wish you knew earlier?
Enjoy the ride. And I sometimes use this. I'll just give you an example. My father, immigrant parent from India, came over, worked really hard, and he was in solo practice. He was a general surgeon. He kept on saying, I will enjoy life when I retire. I'm going to keep working hard 7 days a week, 18 hours a day, but when I retire, I will take the money and I will enjoy it. And the day he retired, like 2 months later, he had idiopathic pulmonary fibrosis, right? And and with that condition, he had to get a lung transplant. Mm-hmm. So they took out his lungs and they put a 35-year-old young woman's lungs in his body. And those 5 years that he lived were tough. Like it wasn't enjoyable. It was a lot of like medications and immunosuppressants. He said, enjoy the ride. Don't make that mistake. And I think it's so easy to get caught up, and you and I are so busy.
Yeah.
And it's just, even at the beginning of my career, you're moving and you're working hard, and I just think it's really important to enjoy the ride. It's really important.
I can't agree more. I was just talking to my husband about this because I chatted with a friend this morning who is very busy on social media, works full time, and I've actually cut back my clinical hours to make more time for the things I do. And I'm very grateful that I did because it allows me to have time with my family, with my kids. And so we were talking about this, and I was like, I feel guilty. Like, should I be working more? And my husband's like, no, like you're spending more time with the people who love you, and that's who's going to remember you. And I was like, yeah, you know what? You're right. And so I think it's so important that because retirement comes and you may not be of best health, enjoy now. If it's taking a day off a week or taking a sabbatical or whatever it is, but like you need to make the time for yourself.
Easier said than done, but I agree. You have to do it.
You have to.
It's easier said than that, especially in our career, like when you're trying to rise and move up, especially at the beginning of your career, you forget that it's important to take the time.
But if you don't try, then it'll never happen because people will keep taking from you, right? So if you don't make yourself a priority, nobody else will.
100%.
What is a non-negotiable, something you have to do every day?
Non-negotiable, 5:20 in the morning, every morning workout. Weekends a little bit later, but it's still going to have it's just a it's a elliptical, says push-ups and some meditation, mindfulness. And if I do that, it's usually a good day. If I don't do that, it's usually a bad day. So I'm superstitious, right?
Yeah.
So if
now you have to.
Yeah, I have to do it, you know. And so that's every morning, and it's my time. Like no one usually calls me or pages me at 5:20. It's my time.
Yeah.
So it's only 30 minutes, but it's my time. Yeah. So it's very nice.
Yeah, it's so good. Yeah, I love my gym time.
Yeah,
too.
yeah.
Not every day, but 3 times a week at least.
Yeah.
What is a life hack or health hack you would share?
I've really paid more attention to sleep now more than ever. Everyone says eat healthy, exercise. We all know that. But I'm really learning dialing in sleep right now. And I'm going to talk about a product I got. I don't have no association with the product, but I got an 8 sleep mattress cover.
I have one too.
Okay, yeah. It is like, every 9 o'clock it says preparing your bed, and it kind of gets you in, and it uses AI, and it auto adjusts every night to make my temperature different where it feels it needs to be. Taking more seriously to go to bed at the same time and wake up. So just getting 8 hours, but changing that time around doesn't help. It's got to be consistent.
Yeah.
So taking sleep more seriously has made a big difference.
I love my 8 sleep.
Yeah.
And I have a friend who she wakes up every morning at like 5 to go to the gym, and she starts getting to bed at 8 o'clock at night. When she first told me that, I was like, oh my God, I can't believe it. But I will like go out with her, and then like 8 o'clock, she's got to go home. And I'm like, oh, okay. All right. And so, it's worth it, right? If you want to do all the things you want to do in life, you need that rest.
Yeah. And it makes a big difference. People, even, it's not the amount of hours of sleep we get. It's multiplied by efficiency. So if you get 8 hours of sleep and you're 80% efficient, or you get 4 hours of sleep and you're 80% efficient, and I get 8 hours of sleep and I'm only 20% efficient, you're going to feel better on your 4 hours because you got better, deeper sleep, right?
Yeah.
So it's not just lying there. It doesn't count.
Right.
Like you got to get good quality sleep. Hacking into like not just the amount of sleep, but getting better quality sleep is really important.
Last question. If you couldn't be a urologist, what would you be?
I'd be a tennis player.
Okay.
Yeah, I love tennis. And my kids play for college. 2 play for college. The third one wants to play for college. And I love watching tennis. I love playing tennis. I love watching my kids play tennis.
Yeah.
I'm obsessed with tennis. I come out to California every year. You have the most beautiful tournament called the BMP Indian Wells Tournament. I've been out here now 9 years in a row for that tournament. It's incredible. And I have not been to Wimbledon, but I want to go to Wimbledon.
You definitely should. You definitely should. Yeah. How do you feel about pickleball now taking over?
Yeah, I'm really upset about pickleball. I mean, I know a lot of people play pickleball, but the reality is that they're not building new pickleball courts.
Yeah.
They're cutting this tennis courts in half.
Right.
So now in our neighborhood, we had 2 tennis courts, and we could always play and get on. Now one's a pickleball court. So everywhere you go, our courts have been taken up. So I'm happy for the pickleball players. That's great. That's awesome. The tennis players are taking a hit.
Yeah. Yeah, for sure.
Yeah.
All right. Well, thank you so much.
Thank you.
This was so much fun,
Yeah.
and we'll definitely connect again in the future.
Thank you so much.
Yep. Thank you guys so much for joining me on today's episode of the Rena Malik MD podcast. If you are enjoying the podcast, a zero-cost way to support is to follow or subscribe to the podcast on whatever platform you're listening or watching on. This allows people to see the value of this information and learn about their bodies and health. I will greatly appreciate it. And as always, remember to take care of yourself because you're worth it.